Right, the session's now recording. This is the second half of your Mod 4 review session. So what you can see on this share screen on the whiteboards, for those of you on your laptops, you see the ribbon that I told you guys about yesterday. So this is that ribbon of like the medications that you are responsible for giving or assisting your patients with. On the left side, you have your ambulance medications, aspirin, oral glucose, and oxygen. And then on your right-hand side, you have these prescribed medications, the bronchodilator inhalers, epinephrine, and nitroglycerin. In the middle is the activated charcoal, and the reason behind that, the textbook defines it as a medication that is sometimes carried at the ambulance or by local protocols, or sometimes it's carried by the patient, but it's not prescribed because they bought it over the counter or something. Things that you need to know about this, that if it's at the back of the ambulance, you verify the expiration date. If it's a prescribed medication, you verify the expiration date and verify the patient's 5 rights, which is the PRTMD, patient, route, time, medication, and dose, right? So this is that ribbon that I was telling you guys about. So any questions about this before I move on to our 4 chapters? Everybody good? Right, so I'm going to stop the screen share and we're going to go ahead and proceed. Okay, so let's start with poison overdose. Chapter 21, poisoning and overdose. Poison is any substance that can harm your body, and toxin is anything that is poisonous that's secreted by bacteria, plants, or animals, right? There's different ways where your body can get poison poison can be introduced in the body. It could be ingested, that means you swallow it. Inhaled, that means it's breathed in. Absorb is through skin, and then injected, it could be because of insects or through needles. Okay, but the injected poison here, the ones that they're referring to is mostly the insect ones. Okay, and so for the ingested poisons, it's just talked about what are the different ways that your patients can be poisoned through ingestion. Okay, so for example, they can be food poison. Okay, so when a patient is allergic to specific food, or when they get exposed to something that is poisonous, such as the pufferfish, your patient can be poisoned through the digestive tract. Question is, for those of you that have the access to the chat box, can you use activated charcoal for food poisoning? Yes or no? Very good. You cannot, right? You do not use activated charcoal for food poisoning. Activated charcoal is mainly used for substances or medications when people overdose in certain medications or certain chemicals, right? It is contraindicated for several things. One, if the patient cannot swallow, if they ingested acids or alkalis, because when they swallow that, when they do vomit that up, it's gonna burn their esophagus, right? For those individuals that swallowed gasoline, right? It's also contraindicated. Okay, so those are the big no-nos when it comes to activated charcoal. Activated charcoal is the dosage for it. The usual dose is 25 to 50 for adults, 12.5 to 25 for pediatric patients, and it's 1 gram per activated charcoal for a kilogram of body weight. Okay? What's the side effects of this one? Well, patients may have black stools, or the patient may vomit or it can cause nausea. And if the patient does vomit, you're going to repeat the dose again. Okay? That is for your activated charcoal for an ingested poison. We also have a dilution. So dilution is anytime you want to weaken or thin down the substance that the patient ingested. So usually we have them drink 1 or 2 glasses of water or milk. This is depending on protocol as well, or depending on what the Poison Control Center tells you. As an EMT, when somebody calls you that they got poisoned, a glass of milk shouldn't be your first response to that. Okay, it's going to be depending on local protocol as well as the Poison Control Center, or what the Poison Control Center tells you. Okay, when somebody gets poisoned, the main thing that you have to worry about these patients is if they're during your assessment with this patient, if there's like any pills or anything that's causing a blockage to the airway, you want to remove that, because remember, you want to maintain ABCs. Provide oxygenation and transport, and keep reassessing your patient en route. And might have to stand by for ventilation because they might have gotten poisoned, right? Or the pills that they took or the chemicals they might have depressed their level of consciousness, right? Then we have the antidotes. Antidotes is anything that would neutralize that. So antidotes are just basically things that would treat the poison or the drug that they overdosed in. For example, narcotics. An antidote for if you overdose in narcotics is what is called naloxone or Narcan. So it reduces the effect of the narcotics when you do overdose in it, such as the depressed level of consciousness and respiratory depression. Okay? It's about 0.5 ml per nostril or 0.4 to 2 milligrams. That's a dosage that we give our patients. Okay? So any questions with the ingested poisons? Everybody good with that? Thumbs up for those of you in the video if it's good, so I can see you guys. Very nice. All right, let's move on. Inhaled poisons. So inhaled poisons, most common one here, carbon monoxide poisoning. Carbon monoxide poisoning is very prevalent. You know it is carbon monoxide poisoning because as per your textbook, the patient will describe a headache that feels like there's a band around their head. You're going to feel dizzy. There's cyanosis associated with it. Okay, so that's the main thing. When it comes to this type of inhaled poisons, the main thing that you want to do for your patients is to remove them from the scene, because it's a poison environment. It's not safe for them, so you want to remove them from the scene so that it doesn't continuously affect them. Okay? If you are not trained, you have to use their 3 R's, which is to retreat, radio, and reassess. That's going to be what you're going to be doing for your patients if they are in an enclosed environment, if there's like chemical gases on there. So remember, it's whose safety is important first. Very good. It's your safety, right? So that's why you don't want to just jump into the scenario over there. You also have smoke inhalation. This is when they're in a burning building. Your patient is going to have difficulty breathing. Same thing. If it's safe for you, go ahead and remove your patient from the scenario, provide them with O2 and continuously monitor them. Okay? Then we have absorbed poisons. Any questions with that inhaled poison? Okay. Main thing about inhaled poison is providing your patients with oxygenation. Any questions with that? Very nice. All right, let's go with the absorbed poisons. This is the one through your skin. Main thing I want to talk about here is how do you treat that? On page 589, if it's a powder, you want to brush it off first, right? Because it might be a white phosphorus powder. And white phosphorus powder, if water gets in contact with that, it can be activated and can burn through the skin. If it's a liquid, you're just going to irrigate it for at least 20 minutes. And if it gets in contact with the eye, that's also 20 minutes as well. So those are your magical numbers, 20 minutes, 20 minutes. Okay? You don't want to use dilute solutions such as vinegar or baking soda. This is not something that we do as EMTs. Remember, you are medical providers. You are not like a quack doctor or anything. So make sure that you do not use neutralizing acids or alkalis such as vinegar or baking soda. Okay? Any questions for that class? Okay. Injected poisons, these are just basic, the books, what do you call this, briefly mentioned about it. There's like 2 sentences about it because you're going to learn this more on Mod 5, okay? So don't worry too much to injected poisons. Poison Control Center is one resource that you can utilize as EMTs because we are not all knowing. So poison control centers might lead us to the right direction on how we're going to assist the patients. Because if you call medical direction, they might tell you, go ahead and call Poison Control Center. Okay? Jubert, H1, can you please take a second to explain what anthrax? Jubert, if you have a microphone, what anthrax is. Okay, so anthrax, that's going to be more covered in the terrorism chapter. So I don't want to talk too much about anthrax, if that's okay, since it does talk about it in depth in the terrorism chapter in Mod 7. It is a form of powder. It comes in the form of a powder, and yes, it can cause some respiratory distress if inhaled by your patient. So yeah, it can be an inhaled poison, but it's more, we counteract that in a different way because since anthrax is a biological agent, you have to know certain things such as decontamination before you start treating your patient. Is that okay with you, Jubert? And for the class, are we good with that quick explanation? Oh, okay, gotcha. So you're asking for your roommate. Tell your roommate to ask their instructor next time. Just kidding. Next. Let's talk about alcohol and substance abuse, right? So alcohol and substance abuse, patients that are abusing alcohol, right? There's like signs and symptoms listed over there: swaying, slurring, nausea, vomiting. But a patient that is stop taking or stop drinking alcohol out of all of a sudden, they tend to go into what we call withdrawals, right? This is when they deprive themselves of the abused substance, or for those of you that smoke a lot and you just quit out of nowhere, you like the cold turkey method. Same thing for those individuals. They go into what we call withdrawals. Delirium tremens is it's a severe reaction of a patient that has been abusing alcohol for like years and years and years. So their body goes in what we call delirium tremens. So they get sweaty, trembling, they get anxiety, some hallucinations, right? There is a medication that we give our patient, or not us, but the hospital gives the patients for this delirium tremens, and you'll learn that more when you get to nursing. So what do you do with your patients when they are abusing alcohol? Simply put, you just monitor your patient for any mental status changes, treat for possible shock, right? And if they injure themselves, you're going to treat that injury and transport your patient. One thing that I do want to cover about this as well is page 594. Okay, if you guys go to page 594 on that note section, it says right there, a patient under the influence of alcohol cannot make an informed refusal or treatment or transport. If the patient refuses treatment or transport, you should nevertheless treat and arrange for transport of patient if patient is necessary on the basis of implied consent, right? Always contact your medical direction for your transporting patient against their will. So a drunk patient basically cannot think for themselves, cannot make decisions, informed decisions. So before you start doing your magical restraints or whatever you want to do, you want to contact medical direction first, or the assistance of law enforcement, right? So any questions with the alcohol abuse? I told you guys these chapters are going to be very short and quick, and I just want to cover the highlights and meats and potatoes. Any questions with that, ladies and gentlemen? Okay, let's move on. Substance abuse. So there's different types of substances. I'm just going to cover what they do and what they do to your body. Uppers are stimulants. This is the ones that excite the users, so commonly seen in like parties, EDMs, raves, right? This is given away, uppers. Then you have your downers. These are the ones that causes your patient to be in a relaxed state. Okay, so it's not to the point where they're asleep, but it's just going to be in their very, very relaxed state. It depresses their nervous system. Narcotics, the difference between this downers and narcotics is used for pain. So patients such as morphine, right? Oxycodone is also another example. Codeine. These are codeine, for example, that's in cough syrups. That's why there was a law that was passed. I think I don't know for other states where you guys live, but in California they have to ID everybody who gets cough syrup medications, especially with codeine, because people abuse it, right? And it's a type of narcotic, okay? And it causes also extreme relaxation as well. Hallucinogens, basically it distorts the perception of the patient. Example of this one is LSD, ecstasy, right? And it causes somewhat of an excitement as well to the patients, but they're starting to see certain things as well, hallucinations. That's why they're called hallucinogens. And then volatile chemicals, just like what you see on page 595, is patients are sniffing it, such as glue, right, or any strong chemicals. So for those of you that love the smell of Sharpie, we might need to be referring you to substance abuse or something, since you like that smell. And don't pretend I don't see you guys in class when you're sniffing my Sharpies as well. Okay. Right, question that I get a lot, HM1 do I have to memorize? Page 596. Like I told you guys, if I don't memorize it, I'm not going to tell you to memorize it. That's just a fair game to do. So if I don't even know all these drugs right here, so I'm not going to force you to memorize these things as well, okay? All right. So what do we do with patients that have substance abuse? Well, same thing that we always do with any patient, right? We do our scene size up, primary assessment, right? Monitor their ABCs, treat for possible shock, okay? And anytime since they are in a substance, right, they are abusing certain substances, they might have injured themselves without knowing it, because somebody who is extremely high, and for example, cocaine, right, they might have broken their bones and they don't even notice it, and they're not feeling it until the high wears off. So you might have to treat those injuries as needed and transport your patient as well. And same thing, just like a patient that is drunk. If a patient who is high on drugs is a harm to themselves or others, can we transport them against their will?
Yes.
Yes, very good. Right? You can transport them against their will every time it's a harm to themselves or others. You have as long as you have medical direction or law enforcement, you can transport them. Okay, so that's basically a quick 7 minutes or 17 minutes for chapter 21. Any questions about that, class? Was that clear for everyone? Okay. Any questions from the chat or those that are in the cell phones? Okay, very good. Let's move on to chapter 22, Abdominal Emergencies. You guys remember the GLASS acronym? Everybody remembers that? Alpha and Bravo, GLASS acronym, okay? This still applies to that, okay? You need to know which organs belong to which quadrant so that when you're asked, hey, the patient is complaining of severe sharp pain on the right lower quadrant, that's basically something, the first thing that you should be thinking is appendix, right? So that's why you need to know the GLASS acronym, okay? So we have peritoneum. Okay, peritoneum is the membrane that lines the abdominal cavity. And then we have the parietal peritoneum and the visceral peritoneum, okay? So does anybody know the quickest way to differentiate? Because a lot of people get confused. What's the difference between parietal and visceral peritoneum? So let me do a share screen real quick, and let me just demonstrate that for you guys, okay? Let me get rid of this. Okay, so the quickest way that I can demonstrate this is, for example, you have your stomach lining, right? This is your stomach here. Okay. And inside your stomach, or like think of this box as a lunch box. Let's just start with that. It's like a lunch box. In your lunch box, you have different food. You have, eggs there. You would probably have, I don't know, cookies. I know it's just like the ground things, but chips, right? And then each of these things that's in your lunchbox, you have to put them in, Ziploc bags, right? You want to make sure that they're not just going to be all over your lunchbox so that they're not spilling everywhere. So you put them in Ziploc bags to protect them, right? So Ziploc that, you put a Ziploc there, put a Ziploc bag there, put a Ziploc bag so that it's not all over your lunchbox. So think of this lunchbox right here as your parietal peritoneum. This is your parietal peritoneum. This Ziploc bags right here, the ones in each of the food that we put in our lunchbox, that's your visceral peritoneum. That makes sense, class? Anybody that confuse anyone? That help out a little bit, a more visual representation of the parietal and visceral, okay? Because that's going to be very important, because when it's a visceral pain, right, visceral pain basically means it's coming from one of the organs in the patient's abdominal area. When we say parietal pain, that's probably more on the stomach lining. Okay, so that's why I wanted to show you guys that description. For those of you that are on the phones, you will see this on the recording as well once you guys get it, okay? Great, moving on. Then we have the retroperitoneal space. That's basically the space behind the abdominal, right? Those are the ones that your kidneys lie on that one. So basically at the back of your abdominal area. That's the retro. That's why retro, going back, right? That's retroperitoneal. There's different types of pain, okay? For those of you that took your mock test, right? You were tested on knowing the different types of pain. Visceral pain, referred pain. Question is, I thought the visceral pain was difficult to point out in one area. Yes, that is true. It is difficult to point out in one area, but when the patient describes a dull pain, right? Or like a crampy pain, that's called a visceral pain, and it's originating from an organ. Yes, you're not going to be able to pinpoint which organ that is. However, if they describe it as a dull pain or an achy pain, that's coming from the viscera, right? So that's why I said visceral pain automatically comes from the organs. Does that make sense, iPhone user? Okay, moving on. Parietal pain, like I said, coming from the parietal peritoneum. It could be because they're having peritonitis, irritation of the peritoneum. So when acid is leaking out of the peritoneum, they're going to feel that intense pain. It could be a very sharp pain. Then you have a tearing pain. Tearing pain is when literally it feels like they're getting torn in half. That's probably your AAA, your abdominal aortic aneurysm. It's a very sharp pain that you feels like you're getting torn in half. And then the referred pain is this weird pain right here. So their shoulder is hurting, but there's nothing wrong. There's no trauma in the shoulder. But the reason why their shoulder blade is hurting is because of a gallstone, right? And why is that? Because the nerves of the gallbladder and your shoulder blade, they basically intertwine when it's on the spinal cord. So when the gallbladder, if something's wrong with the gallbladder, the nerves basically push on the nerves of your shoulder blade as well. So hence, you feel the pain on the shoulder blade, but it's actually being caused by the pancreas. Everybody clear with that referred pain? Okay, so those are the different types of pains right there. Now I'm gonna quickly go over the different types of conditions, okay? Appendicitis, basically the inflammation of the appendix. It's on the right lower quadrant. It starts in the middle, actually. It starts in your navel area, then it travels to the right lower quadrant. Peritonitis is basically an irritation of the peritoneum, such as for those of you that have ulcer, right, or those that have hyperacidity. Acids tend to like burn the lining of your stomach, causing peritonitis. Then we have cholecystitis or gallstones. It's the inflammation of the gallbladder. This is dangerous because your gallbladder stores bile, which is responsible for fat breakdown. So if that's the case, then when there's something wrong with the gallbladder, it's not going to break down. It's not going to release the bile properly. And then we have pancreatitis. Pancreatitis is the inflammation of the pancreas. That can also be an issue because pancreas produces a hormone, okay, a hormone called insulin, and insulin is responsible for your sugar intake or your glucose intake for the cells. Then we have GI bleeding. GI bleeding is basically bleeding in the gastrointestinal. It could be because of gastric ulcers, or it could be because of extreme hyperacidity, and you're gonna know it's a GI bleeding because your patient is gonna vomit like actual blood that looks like coffee grounds, or they're gonna poop out blood that's actual big clumps of blood, okay? And then we have the abdominal aortic aneurysm. That's basically the AAA. This is basically the aorta, as we learned in the cardiac emergency, the aorta weakening on the wall, so it feels like it's about to explode. It's dilated. Okay, and then we have hernia. Hernia is basically your abdominal wall muscles weakens. This is common for those of you that does extreme lifting, okay, without proper preparation of your body. So the organs basically, what do you call this? The organs protrude in the weakened portion of the abdominal area, causing them to have that bulge, okay? And can we repair hernia? Not us, but is a hernia repairable? Yes, okay, so we can repair hernias, not us specifically as EMTs, but the surgeons can do that, okay? And then we have renal colic, basically kidney stones, right? Kidneys, you're gonna feel that because you're gonna have some pain on the side, right? It's called a unilateral flank. And then it could also be a cardiac involvement pain, because the reason behind that, the aorta, right? When there's something wrong with the heart is close to your abdominal area. So sometimes that heartburn is being masked. It's actually an acute myocardial infarction that's about to start or that is starting, but they think it's an abdominal pain right there. So those are your different types of abdominal conditions. Are there any questions about that class? Okay, question is, can menstrual cramps be considered as visceral pain? Not necessarily. Visceral pain is more located inside the peritoneum, okay? So it's not going to be considered, menstrual cramps would not be considered a visceral pain. What was the last pain you said? Referred pain. That was the last pain that I mentioned, referred pain. Okay, so any questions with that class? Right, so what is the main thing for assessment for these type of patients? There's really nothing special about it, except for the fact that we still do our scene size up, our GLC, ABCTP for our primary assessment, OP, QRST, and ample. The only difference is if they are a female, you have to ask an additional question when they're females, if they're possibly pregnant, right? Because the reason why is it might be an ectopic pregnancy, and that's the reason why they're feeling some abdominal pain, okay? And for the examination of your abdominal area, what's the proper way of inspecting or assessing the abdominal area? Bravo, I know you know this because I came in and H1 Duke wrote this on the board. Who can tell me what's the proper steps of assessing the abdominal area? IAPS. Very good. So what does IAPS stand for? What's the I? Somebody from Bravo. Oh, turn on your mic and start talking. What does IAPS stand for?
Inspection, auscultate, palpate, percussion, and smell.
Okay, so very good. So basically you start with, you start looking first and then you listen for the bowel sounds, right? Inspect, auscultate, right? So, and then you start palpating. So that's basically when you're using your fingertips, right? To do the palpation of the 4 quadrants of the abdominal area, and then you percuss, right? You basically tap into the abdominal area to see if there's any like gas out there or any distension. Somebody mentioned the third P acronym for any tenderness, rigidity, distension, or any pulsating mass. That's what you're going to do for that, okay? For somebody who is experiencing abdominal pain, you're going to reassess your patient every 5 minutes, right? That is listed on your book, page 614. And you want to make sure that you assess your patient's ABCs and stand by for any possible vomiting. Okay? And you want to make sure that you reassess your patients every 5 minutes as well, since your patient is considered unstable. Right? If your patient is experiencing abdominal pain, if they do not have any compromise in their spine, you can have them flex their legs if needed, because flexing your legs releases that tension in the floor area. So it's less painful for your patient, right? Or sometimes we transport them in the position of comfort because it helps calm the patient down. And for the female specifically, when you have severe menstrual cramps, you go into the fetal position, right? So sometimes in individuals that have severe abdominal pain, they might be more comfortable in the fetal position. Okay? So that's basically for your abdominal emergencies. Transporting your patient, monitoring their ABCs, giving them O2 if necessary, and reassessing them every 5 minutes. No specific medication that we have to give. Any questions for that class? Okay, good. So we're on our last 2 chapters, behavioral and the renal and hematologic emergencies. Let me pause you guys real quick and just get some water because my throat's running dry a little bit. Okay, so I'll be right back. All right, I'm back, everybody. So let's go ahead and finish off our last 2 chapters. We have behavioral emergency on chapter 23. Probably everyone's favorite when it came to the practice scenarios, right? Because everybody was clueless on what to do to a behavioral patient. Do I strap them down? Do I tranquilize them? Can I punch them in the face because they don't want to answer my questions, right? Trust me, Air Force skills, behavioral emergency is one of the highest failure rates because students practice so much and everything, but they forget to practice their behavioral emergencies. It's a very challenging one. Okay? So behavior is the manner in which a person carries themselves. It becomes a behavioral emergency when their manner becomes unacceptable and intolerable to the patient, the family, and the community, or when they become a harm to themselves and others. Before you start thinking that the reason why your patient is having a behavioral emergency is because they have a psychiatric condition, you want to take note of possible physical causes first. Maybe it's hypoglycemia, it might be hypoxia, extreme environmental temperatures. There's several lists on there as well. So you want to think of medical and traumatic causes first. So when a patient is experiencing behavioral emergency, they might just be in a situational stress reaction mode. Okay, so when the patient is extremely stressed, you want to make sure that you're not rushing your patient. Okay, you want to remain calm, because calm equals calm, right? You want to stay calm as much as you can, and you also want to try to gain trust with your patient by listening to them, because that's a very important thing there, and not lying to your patients. You want to be as honest as you can. Okay. And then the book also talked about acute psychosis as a behavioral emergency. So this is when the patient has a acute, means it happens like all of a sudden, right? So all of a sudden they start seeing hallucinations, delusions, catatonia, and thought disorders. All those are on page 623, right? So those are basically acute psychosis, an example in acute psychosis. So what do you do when you encounter a patient that is currently experiencing any of these, like hallucinations and delusions? Well, one big thing that you have to do is do not play along their hallucinations, right? Do not be tempted to play along. And you want to remain as calm as you can, because calm equals calm when it comes to behavioral emergency patients. Okay? More advice on page 624, identify yourself, make eye contact, do not be judgmental. And the personal space, stay at least 3 feet, magical number right there. Stay at least 3 feet from these type of patients, because that's your personal space, and you're gonna use restraint as necessary, okay? So how do we treat behavioral emergencies? Well, same thing, is we do our scene size up, primary assessment, secondary assessment. If the patient does talk to us, majority of your time when it comes to behavioral emergency is spending time talking to your patients, right? So you want to make sure that you also you do not want to cause your patient to be in an aggravated mode. Don't piss them off, right? That's why you want to listen and be as calm, as professional as you can. And you're going to treat any life-threatening injuries if they do have one, right? So for those of you that practice the behavioral emergency, what is one focused physical exam that you do if you don't know what's going on with your patient? What is one thing that we can utilize?
Auscultate the lungs.
Very good. Auscultating the lungs. Okay, that's the main thing that you can do. If all else fails, if you're like, I don't know what the heck is going on with this patient, I checked the blood glucose, nothing's wrong with the blood glucose, I did the FAST, the Cincinnati pre-hospital stroke scale, patient doesn't have a stroke, what else do I have left? Well, auscultate the lungs, okay? At least that will give you points for your medical skills simply by auscultating them, okay? So any questions with the behavioral emergencies class? Okay, let's move on to suicide. Suicide, patients that are at risk at suicide, the ones that are in depression, the ones that are in high current or recent stress levels, recent emotional trauma, people in the ages between 15 to 24 or over 40, those that have alcohol and drug abuse, those that have history of threats of suicide, previous attempts of suicide, has a suicide plan, and sudden improvement of depression. Those are the individuals that are all red flags pointing towards possible suicide. So what do you do when it comes to this patient? Well, you want to make sure that since the patient, right, is a possible harm to themselves and to others, can we restrain the patient when they're going to harm themselves? Can we restrain the patient? Yes, right? So first of all, start talking to them first, right? You want to convince them, but if all else fails, you want to make sure that you have the backup, right? Law enforcement and other EMTs to properly restrain the patient, and medical direction has approved that as well. You cannot just, you cannot just restrain your patients, okay? So that's the biggest thing when it comes to possible, potential, or attempted suicide, okay? Then we have aggressive or hostile patients, right? Aggressive or hostile patients. Some patients are very, very violent, right? You have to make sure that you distance yourselves from this individual. So you want to make sure that you have an escape route if you're responding to an apartment or a house. You don't want to barricade yourselves and get cornered by the patient. And if the scene at any time becomes unsafe, you have to, I know it kind of sounds dumb, but you have to retreat, radio, and reassess. You literally have to leave the scene so that you don't harm yourself and your partner, Okay, I don't care how much martial arts training you are. It's not the time to show off your WrestleMania moves and like bring your patient down, and it's just not going to happen. Okay. When it comes to that as well, the law enforcement definitely has to be present on there because of the violence present. It's not a safe scene, so until the law enforcement says, "Hey, the scene is safe now, patient, you can help us restrain the patients," and that's the only time that you're going to be coming in. Speaking of restraints, since we've been mentioning this already, we have several rules that we have to know for restraints. One, it has to be a short restraint. I mean, actually, a soft restraint. Mute your mics, please. Okay, soft restraints. It has to be one on each extremity, and that's why there's a minimum of 4 people, because one person on each of those limb, and the patient has to be face up, right? They have to be in the supine position. Never hog tie. Do not hog tie your patient. They cannot be in the prone position because that's going to cause some positional asphyxia, right? That means that they're going to stop breathing because of the position that they're in. Patients might also experience excited delirium, which patients will only experience this or usually experience this right after using what drug? What drug? Who knows? Those that are using the mic. What drug is this? Uppers. Very good.
Okay.
Cocaine, right? Amphetamine, right? So any of those uppers, right, can cause an excited delirium. And that's why, if possible, all these patients might also need to be restrained, right? When you're restraining your patient, you have to monitor your patients as often as you can, depending on local protocol. You also want to reassess the CSMs, the circulation, right? The sensory, can you still feel this? Can you still move your fingers? Okay? And you have to transport them to an appropriate facility. Not all facilities can handle behavioral emergencies, okay? And no, it doesn't have to be into a mental asylum, right? Hospital, not asylums, okay? There's one student from previous class like, oh, so do we have to bring them to asylums? No, you just have to bring them to hospitals that can treat the behavioral emergency, okay? And when it comes to medical legal considerations, right, patient's consent has to be, at least you want to attempt to try and get the patient's consent, right? Don't just assume right away that, okay, I'm not going to try and get this. Try to talk them out of it, and once they start to become a harm to themselves or others, hey, as long as you have law enforcement and medical directions back up, you're more than, you can basically restrain your patients as long as you have those 4 EMTs or 4 individuals present. That's going to help you restrain your patient. Okay? So that's basically for behavioral and suicide emergencies. Any questions with that specific chapter? Again, no specific medication was administered, just basically how you're going to handle your patient and how you're going to handle the scene. Right? Any questions with the behavioral emergency? Okay, very good. 1 chapter left. Last one, guys. Right. So we have hematologic and renal emergencies. Okay, hematologic is basically the blood. Renal emergencies is for the kidney. First hematologic emergency is blood clotting. Okay, so some individuals have a problem with clotting. So this is what we call coagulopathy. So this is the normal, the patient loses the normal ability to form a blood clot, right? So there's different examples that the book listed. For example, hemophilia is a disorder that prevents them from clotting, right? With these type of individuals, you have to be very careful because when you give them aspirin, it might cause them to have a thinner, it might cause them to bleed out, right? So individuals that they cannot clot, when you give them aspirin, which is also a blood thinner, that can be very, very dangerous to those type of patients, okay? So how do we treat them? Well, same thing, BSI, seen safe, GLC, ABCTP for primary assessment, OP, Curiosity, and ample for history taking, right? And then just notifying the hospital that you have a patient that has a coagulopathy, and ensuring that as you're transporting your patient, you want to monitor for signs and symptoms of shock because they can bleed out in the middle of it internally and you're not seeing that. So you do want to monitor those type of patients, okay? So that's for coagulopathy. And then you have anemia. Anemia is basically abnormal or lack of normal red blood cells. So anemia can be acute, basically when your patient goes into a trauma or an accident, be an acute anemia. It could also be a chronic anemia to where heavy menstrual period or diseases in the bone marrow causes them to have lack of red blood cells. So that's anemia. Another type of anemia is the sickle cell anemia. Sickle cell anemia basically means that the red blood cell is not perfectly round shaped. So basically with that issue, the red blood cell is not going to be able to carry oxygen. It's no use. It's basically, like I was using as an example earlier in class, it's a deflated tube. So there's no point in using a deflated tube when you're doing river tubing, right? So you want your tube to be fully inflated so that the oxygen will jump into it, okay? There's signs and symptoms that the patient can feel or have when they do have sickle cell. They can have sickle cell pain crisis. They can have acute chest syndrome. They can have priapism, stroke, jaundice, right? All those are on page 640. So how do we treat this type of patients? We administer them O2, monitor for signs and symptoms of shock, and transport your patient to a designated stroke center. The reason behind that is because the red blood cells, the sickle cells, can clump up, okay, into the blood vessels, and it's going to cause some blockage, right, into the brain, right? And if there's blockage in the brain and the blood vessels, oxygen is not going to be received in the brain, hence stroke is a result of it. Stroke comes out as a result of that, right? So that's why you want to make sure that you transport the patients to a designated stroke center if possible, okay? So any questions about those hematologic emergencies? Everybody good?
Excuse me, HM1.
Yes.
I was asking, this is McCurry. I was asking in class today, so can sickle cell anemia, can't they form blood clots like the cells that are deflated? Can't they hook together and then get stuck in the vessels?
Yes, and that's why your patients experience what we call sickle cell pain crisis.
All right, that's what it is.
Yeah, they tend to clump up in the capillaries specifically. So that's why. Okay.
Thank you,
question, Harry?
Yes, it did.
Okay, very good. All right. Now let's go to the last portion of this one, which is the renal system. Okay, so there's different types of diseases there. As long as you know what the diseases are when it comes to signs and symptoms, then you should be good. For example, urinary tract infection. When your patient has a urinary tract infection, they're going to have it's going to be painful and frequent urination. If this is not controlled, it can turn into pyelonephritis. That's basically the infection goes up all the way up to the ureter, all the way up to the kidney, right? So that's your pyelonephritis. So that's why UTIs have to be taken care of right away. And then you have kidney stones. Kidney stones is going to be painful for your patients, and they're going to feel that unilateral flank, basically pain on the side of your patients, right? So this can happen because of improper diet. Because it's very painful, your patient can experience nausea and vomiting as well, right? So when something is so painful, especially when it's passing through the ureters, the patient can experience excruciating pain, causing them to have that dizziness and that nausea and vomiting feeling, okay? Then you also have patients with urinary catheter. For your patients with urinary catheter, the main thing that you have to take note about this is because since it's embedded in them, right, it's in their body, it might cause some UTI as well. And especially if they're not cleaning it, or if they're at home and they have urinary catheters, and they're not properly cleaning it, that's the main thing that you're going to see as an EMT, is that infection or that UTI, possibly UTI on your patients. And there's really nothing that you can do with that except transport your patient. If your local protocol allows you to, maybe they're going to ask you to remove the urinary catheters, but that's going to be depending on local protocol. Okay, and in nursing, you're going to learn how to insert and discontinue a urinary catheters in a hospital setting. Okay. And then you have renal failure. Renal failure is basically when the kidneys basically lost their ability to filter blood, right? The kidney is very important because it filters all the toxins in your body. So when they fail, okay, there are several things that has to happen. So either they go through dialysis, they go into medications, kidney transplant, right? But when renal failure is not taken care of, it turns into what we call end-stage renal disease, okay? End-stage renal disease, if the patient wants to survive or they're basically going to have to go through dialysis. Okay, dialysis is basically a way for what do you call this? It's an artificial way for the patient to have their toxins filtered out of your body. Because remember, the kidney cannot do it anymore by itself. So that's why they go through dialysis. Dialysis takes about 3 to 4 hours. How long does dialysis take again? 3 to 4. Okay, so 3 to 4 hours. And it takes a while, and the patient has to go about three times a week. There's 2 types of dialysis: hemodialysis and peritoneal dialysis. Hemodialysis is used in a patient's AV fistula. Okay, so the AV fistula is a surgical implant on the patient's either their bicep area, right, or they're close to their thoracic area as well, and they get hooked up to a machine. They have to go to a dialysis center to do that because it is very rare to have a dialysis, an actual hemodialysis in the patient's home. So think of hemodialysis as AV fistula, and you have to be connected to a machine. Okay, and then you have peritoneal dialysis. Peritoneal dialysis is basically on the abdominal area. There's 2 types of peritoneal dialysis. We have the CAPD, continuous ambulatory peritoneal dialysis. Basically uses gravity. You lift the bag to put all the fluids in there, and then you drain the bag to get all those fluids that absorb the toxins in the abdominal area. Then you have the continuous cycler-assisted peritoneal dialysis. So this is a machine that the patient can use that lifts the bags and puts the bags down while they're asleep, so they don't actually have to manually do it. But it's also in their abdominal area. So that's the peritoneal dialysis. Okay. So any questions with that class? Everybody good with that? Okay. And last but not least, the medical emergencies when it comes to end-stage renal disease. Complications that you might get from this one is the bleeding from the AV fistula or infection. If the AV fistula is bleeding, you have to control the bleeding, right, by direct pressure. And you're going to learn this all in Mod 5, but you have to control the bleeding of the AV fistula. And you want to try to avoid putting on a tourniquet on that one because the AV fistula might need to be repaired. And if you put a tourniquet on, it might destroy the AV fistula that they put. You also want to make sure that you monitor your patient's ABC and treat for possible shock because remember, end-stage renal disease, there's a lot of toxins in the patient's body and it can cause them to go into septic shock. So same thing, whether it's septic shock, cardiogenic shock, or whatever shock, you will treat shock all the same way. So provide them oxygen, place them in a supine position, cover them with a blanket, and transport them as soon as possible. Okay? And last but not the least on there, page 648, kidneys are the most commonly transplanted organs. Why did they put that there? I'm not sure why, but anytime you see the words most, least, greatest, biggest, smallest, largest, probably a good thing to remember. Okay? That's basically the 1 hour review session, or 40 minutes actually, a 50-minute review session for those last 4 chapters. Are there any questions, comments, concerns, or anything that I can clarify for the group? Everybody good?
Hey, 81. I have a question.
Yes.
All right, so I was doing the mock test, and it's a question that says a 71-year-old man on set, severe respiratory. He is anxious but alert and states, "I feel like I'm dying." His vital signs. His pulse is 122, respiratory rate is 40, blood pressure is 21, 210 or 108, and his pulse ox is 89%.
Mm-hmm.
And in class, we was in the lab, 82 told us the answer would have been ventilation because 8 and 28 ventilate. But Gilio had submitted her answer and it said administer non. So which one would be? Because since we was basing off 8, telling us between 8 and 28 we need to ventilate.
Let me look that question up specifically so I don't give you the wrong one, right?
It's number 14 on the mock test.
Number 14? Okay,
Yes.
So let me look at question number 14 on that one. All right, let's see here. Number 14. All right, 71-year-old male complains of acute onset of severe respiratory distress. He is anxious and states, I feel like I'm dying. His vitals are, pulse is 122, respiration is 40, blood pressure is 210, pulse ox is 89. You should first. And what was the answer that was provided to you guys?
82 had gave us initial positive pressure ventilations, but Giglio had submitted and the right answer was administer 15 LPM of oxygen via non-rebreathing.
Mm-hmm. I'm gonna look this up. Let me see real quick. Probably just like an error on there, but yes, because the respiration rate is at 40, and that's like above 28%, and his pulse ox is 89. The non-rebreather won't be doing a lot for your patients. So a positive pressure ventilation is definitely something that you want to consider for this type of patient. If that's what do you call this? If it's the non-rebreather that showed up, I'm gonna make sure that I do change that. But yes, it is number 14 should be letter D for positive pressure ventilation, simply because of the fact respiration at 40, you're not breathing properly. Non-rebreather mask is not going to do anything for your patient. Does that answer your question?
Yes, it does. Thank you.
Yeah, thanks for bringing it up, and I'll make sure that I do edit that on the mock test as well. Any more questions, ladies and gents? All right. So if you guys don't have any, don't have any questions, right? Chat about likely ventilation. Yeah, ventilation. We're definitely going to do ventilation. Yes, for that number 14. So I'll make sure that I do clarify that as well in the announcements. But if you selected ventilation, that is the one that I would pick as well. So it's probably just a error on there. Okay. Other than that, thank you for showing up. Like I said, 50% class participation. This review sessions will keep on going. When I only get 20 students on here, I'm gonna stop doing this, right? Because I'm setting aside personal time for this, so I expect the same from my class as well. So no more questions. Have a good night. Good luck with your tests. I've unlocked all the homeworks and assignments for you guys in the MyBrady lab. So feel free to do your homeworks again, chapter tests, okay? And as well as your mock test. And I'll fix the answer for that specific test question as well. I'll be available all night. Okay, I'm a late sleeper, so if you guys have any questions, especially for those of you that are nervous Nancys that are going to stay up till like the crack of dawn, I highly do not recommend that. But if you guys do so, just send me an email via MyBrady, and I will be more than happy to answer you guys. Other than that, start logging out if you don't have any questions. So I can stop the recording, and I can convert this to YouTube videos, so I can do that. Will I be in your PD session tomorrow? No.